We're at the IAS meeting here with Lynne Mofenson, who's with EGPAT. The conference is happening here in Paris, so, but that doesn't mean anything, because all that matters is that we're going to talk about pediatrics and the issues that are surrounding that area of work. And you're going to talk, being from Elizabeth Glaser Pediatric AIDS Foundation, you're pretty connected on what's happening in that field. It's very important to you, and I know some of the companies that are really investing a lot into learning more about the needs for the Pediatric Foundation, or Pediatric AIDS. So I'll let you give us the information, and I'll jump in where I feel we can maybe ask a question or two.
Okay, that's fine. So what we've moved from prior meetings is we've moved from what is it that works to how can we implement what we know works. And that's been a big focus of this meeting. So for example, there's been a lot on testing of infants. How can you best identify HIV-infected children? Because in order to save people's lives, you have to be able to identify them.
And do it cost-effectively, too.
And do it exactly. So there will be some presentations on point-of-care testing, particularly at birth. So with a standard HIV test, it can take as long as a month for the results to come back. With point of care, you can diagnose that baby right away, including at birth, and start them on treatment right away. So point of care looks to be very cost effective. There's a poster that's going to be discussing this, and it will save lives. Other discussions around testing is how to best target testing outside of the newborn period. And there's been some studies showing that going to TB clinics, malnutrition clinics, children who are in the hospital, that's a very good way to identify infected children that haven't been identified before.
So not all children get tested when the birth happens.
That's right.
And that's the real problem at this point.
Yes, that is a problem.
Because the mothers don't even know they're positive.
That's true. And also what happens is they may test negative at 6 weeks, but they're breastfeeding for 2 years.
Right.
And if the mother isn't on treatment or she's skipping her treatment, they can become infected, and you may not recognize that for years unless they get tested.
Are we talking mostly developing world?
Yes, I'm talking developing world. I think the focus here is really on low resource settings, because that's where the problem is.
Right, exactly. Because most of the children are identified, most of the women are identified as being positive before they give birth, and then the children are they're treated as a
I would say in the U.S., 90% of women are tested in the U.S., but globally, only about 60% of pregnant women ever get an HIV test. So if they're not tested, they can't do anything to prevent transmission. Another focus of the meeting is on very early treatment. We've gone from, you only treat if CD4 count is under 200 or under 500 to now you should treat every child as soon as you know they're infected. And there are several studies showing benefits to starting treatment very early in life. There's a study that's going to show decreased mortality, decreased morbidity when you're starting treatment under 3 months of life. And other studies showing starting even earlier decreases the viral reservoir. So
it's just now seeding. It's just seeding the entire body.
It's just seeding. That's right. So if you can catch that early, you prevent both seeding of other places, but you also lower the amount of virus that's within the child. Right. And they're actually going to be tomorrow in a late breaker poster presentation talking about a child who had very early treatment, starting at just a few days of age, who was treated for a year and then stopped, and now is 8 years old and has been in viral remission for a prolonged period of time. So we now have 3 babies with very early treatment who's gone into viral remission. But I'd like to remind the audience—
This is just early.
This is well, it's not even that. We should not be stopping treatment outside of a research setting.
Right.
But we have now 3 children who have had prolonged times off of treatment now, who had treatment very early in their life. So another good reason for identifying children very early and starting them on treatment very early. Another important focus of the meeting is on prevention of mother-to-child transmission. There'll be some studies showing we're doing very well, very low transmission rates, but still transmission rates occurring postpartum. But importantly, there are a number of studies looking at the newer drugs in pregnancy. So dolutegravir, for example, an integrase inhibitor, is moving to be the first-line therapy in many countries, but it hasn't really been evaluated in pregnancy.
Right.
And so there are several studies that are being presented showing that dolutegravir-based regimens appear as safe in pregnancy as efavirenz-based regimens, don't appear to be associated with adverse pregnancy outcomes or birth defects. So that's very reassuring, so that countries can include.
Because we want the best drugs that are going to be most effective and have most durability, et cetera, et cetera.
Right, and you don't want to have a country moving to a first-line therapy that's never been looked at in pregnant women, because you want your pregnant women to be getting the same therapy as
right, and you don't really
people.
have the ability to study that in the United States because, like you said, we don't seem to have that any children born out of through a pregnant woman who has like not been tested, and it's a different, totally different circumstance.
Yeah, and
so,
but I think it's good news also for the U.S. because dolutegravir is a first-line therapy in the U.S. and people want to use it in pregnant women, but they were very concerned regarding birth defects or was there preterm delivery. So I think this meeting has gone a long way to reassuring people that that looks good. And they also had a presentation on raltegravir, which is another integrase inhibitor, an earlier one, that showed no increase in birth defects. So that's very good news.
A lot of good news at the conference.
Yeah, good to see. Oh, and I guess the other thing I wanted to mention is that on Wednesday morning there is going to be a satellite on safer conception. So there's been a consensus paper developed and published in AIDS Behavior saying that people need to acknowledge that HIV-infected people may want to have children and that they need to be able to plan their pregnancies, and how can we better assist them in reaching their fertility goals. And it emphasizes testing. You have to be tested. It emphasizes prevention, the use of PrEP in HIV uninfected women who are at risk, and treatment in those who are infected.
Exactly. Yeah.
So that's a very important thing too, and that's more of a tell the physician type of thing, because I think what happens is physicians sometimes treat patients as if they shouldn't have children.
Yeah, I think it seems logical to do that, but like you said, it shouldn't be an issue. It should not be put in there as how can I say, their personal.
Yeah, it's not a negative thing.
Right, and it's science that we've proven. As soon as we prove science, that's the other thing. We have to make sure people understand science is evolving. If it didn't evolve, you and I wouldn't be sitting here. There'd be no conference.
Right.
Every year we learn something new. That didn't say we learned something incorrectly. It's just that we didn't have enough information.
Sure, and it evolves. You learn a little bit here, and then the next year you learn a little bit more, which helps you to move to something better.
Right. And you've already said there's more things we're learning in this whole picture that's going to make it more solid.
Yes.
In the very next number of months or years.
Yes, but I think the big difference between this year and many other years is that we finally have something that we can implement.
You can bank on it.
Yeah, and we need to learn how to do that better.
Right. Well, we're definitely going to look forward to that. The other thing, I know that you got to run, but I wanted to make sure we covered anything that you felt would be important to embrace at this conference, because I really feel that we don't get enough information out about pediatric AIDS. You've been a staunch supporter of doing that for us and with us, and we really appreciate that. So,
well, I think the only other thing I would say is a place where we have a gap, and that gap is with these very new drugs. The newest integrase inhibitor, the long-acting drugs.
Oh, yeah.
Those studies have not been done in children yet, or in pregnancy yet. And so I guess I would urge the research community to not forget there's still infected children out there.
I visit with them, and I know a number of doctor advocates visit with them, and we're going to pass that on and make sure it does happen.
Good.
Thank you so much.
You're
I really
welcome.
appreciate taking the time again.
It's a pleasure.
Look forward to maybe seeing you at CRY.
Okay.
Okay, Boston.
All right.